Good evening and welcome to the 172nd Anniversary Discourse and Awards at the New York Academy of Medicine. I'm Jim Flynn, Chair of the NYAM Board of Trustees, and I'm delighted to congratulate all of our newly inducted fellows and members and to welcome you here tonight to honor our distinguished awardees. At NYAM, our vision is that everyone should have the opportunity to live a healthy life, no matter who they are or where they live. The video that was playing as you arrived in the auditorium tonight shared the core belief that drive NYAM's work. I'd like to highlight one of these beliefs that feels especially relevant to the Discourse and Awards program. We believe in fostering an environment where expertise and compassion come together to build a brighter and healthier future. This year's discourse speaker and honorees are nationally renowned experts and leaders in research, academia, clinical practice, public health, and health policy. Through their expertise and compassion, they have led medical breakthroughs, changed policies, addressed longstanding health disparities, and transformed medical education. Today, we bring them together not only to honor their accomplishments, but also to inspire our community of health professionals and reaffirm our shared goals. We are honored to welcome Dr. Otis Brawley, one of the country's foremost experts on racial and ethnic disparities in cancer diagnosis and treatment. As this year's discourse speaker, and we are incredibly pleased to recognize the following honorees for their outstanding achievements in their fields: Dr. Nancy Wexler, Dr. Diana Mason, Dr. Mary Bassett, Dr. Philip Pisa, and Dr. George Thibault. Supposed to clap for them here. I would like to thank the members of the awards committee, chaired by NYAM trustee Dr. Mark Grodman, who considered dozens of potential honorees to select the very distinguished group being honored tonight. Those committee members are Dr. Sonia Angel, Dr. Wendy Chung, Dr. Barry Collar, Dr. Mark Grodman, Dr. Harry Pincus, Dr. Vivian Pinn, Dr. Claire Pomeroy, Dr. Elena Rios, Dr. Maria Vezina, and Dr. Judith Salerno. And now, thank you, Mark and everybody. And now it gives me great pleasure to introduce the president of the New York Academy of Medicine, Dr. Judith Salerno.
Good evening, everyone, and thank you so much. Let me add my warmest welcome to you all. Tonight, we're gathered to celebrate excellence in medicine and health, the excellence of our distinguished 2019 honorees and of our fellows and members, including tonight's new inductees and the 30-year fellows who we'll recognize later this evening. We thank them for dedicating their careers to improving the health of the public. At NYAM, we're champions for health equity. We can't say that often enough. We tackle the barriers that prevent every individual from living a healthy life. We generate the knowledge needed to change the systems that prevent people from accessing what they need to be healthy: safe and affordable housing, healthy food, healthcare services, and more. Through our high-profile programming for the general public, focused symposia for health professionals, and the participation of our dedicated fellows and members, we engage the minds and hearts of those who also value health equity. An example of our commitment to health equity is the new awards program that I'm excited to announce tonight. NYAM has partnered with the National Medical Fellowships to establish 2 new annual awards in honor of Dr. James Mckeen Smith, a highly accomplished African-American physician in the late 1800s who was posthumously honored with NYAM Fellowship at last year's Discourse and Awards ceremony. A scholarship award will be given to a medical student who exemplifies the qualities of Dr. Mckeen Smith through his or her commitment to academic excellence, leadership, service, and research. And a research award will be given to a physician who has published work in the past year addressing health disparities. Both awards will be open to those of African American, Afro-Latino, or Native American descent. The application will soon be open. Please see tonight's programs for more detail. I also invite you to join us to the inaugural Dr. James Mckeen Smith Lecture and Awards event, which will take place at NYAM on April 1, 2020. We look forward to continuing to honor Dr. Mckeen Smith's legacy by supporting the education and research of the medical profession's diverse leaders. You can also create your own legacy by naming a seat in Hosack Hall, where you're sitting this evening, for yourself or a loved one, a mentor, or a colleague. The seats in this hall are, you'll see the plaques on the back of the seats, where they are given in honor or memory of people to mark their careers and contributions in the health professions. You can find more information on the Name Your Seat program near the reception following tonight's program. It's now my honor to introduce the 172nd Anniversary Discourse. This year's discourse speaker and my friend and colleague, Dr. Otis Brawley, is a global leader in cancer research and in eliminating health disparities. His work focuses on closing racial, economic, and social inequalities in the prevention, detection, and treatment of cancer. Dr. Brawley is the Bloomberg Distinguished Professor of Oncology and Epidemiology at the Johns Hopkins University. He leads a broad interdisciplinary research effort focused on cancer disparities at the Johns Hopkins School of Medicine, the Bloomberg School of Public Health, and the Sidney Kimmel Comprehensive Cancer Center. From 2007 to 2018, Dr. Brawley was Chief Medical and Scientific Officer of the American Cancer Society, where we got to work together on many occasions, where he oversaw the largest private program supporting cancer research in the US. Prior to that, he served as medical director of the Georgia Cancer Center at Grady Memorial Hospital in Atlanta from 2001 to 2007. Among his numerous awards, Dr. Brawley was a Georgia Cancer Coalition Scholar. He received the Keys to St. Bernard Parish and received the U.S. Public Health Service Meritorious Service Medal for his work as a commissioned officer in the aftermath of Hurricane Katrina, where we were both there serving at the same time. He's a recipient of the Department of Defense Uniformed Services University Distinguished Service Award for his contributions to military education. He's a member of the National Cancer Institute Board of Scientific Advisors, a member of the National Academy of Medicine, a fellow of the American Society of Clinical Oncology, a fellow of the American College of Epidemiology, and a master of the American College of Physicians. Please join me in welcoming the Academy's 172nd Anniversary Discourse speaker, Dr. Otis Brawley.
Thank you very much, Dr. Salerno. It's been a privilege to know you from your days at the NIH through your days at Komen. And I want to congratulate you on your recent induction into the National Academy of Medicine, just last week, actually. It's truly an honor, and indeed I'm very humbled to be the 172nd discourse speaker. Looking back at previous speakers from Donna Shalala to C. Everett Koop, it's an amazing list, and thank you for the honor of joining them. I also want to thank Ms. Donna Fingerhut for arranging all of this, and I want to acknowledge a couple of mentors in the audience, Dr. Danielle Laroc-Corina, Dr. Philip Pisa, and Dr. Arthur Rubenstein have all touched my life as I've come along in medical oncology, and I want to acknowledge them. And because they're in the audience, you're going to get a good talk tonight. I am a medical oncologist and epidemiologist. I'll apologize ahead of time. I'm going to show you some slides with numbers and graphs and things. And these are my disclosures. A couple of years ago, I wrote a book that got on a few bestsellers lists. I'm not here to push the book tonight. I'm going to talk about a brief history of cancer and cancer trends, the causes of cancer, the changing definition over time, and indeed we have a 21st century definition of cancer that's very different from the original definition from the 1850s that we used really into the 1990s. Talk about some issues in cancer control, and then define disparities in cancer. First, this is the first known written mention of a disease which we now call cancer. It talked about something that grows, it kills, and there is no treatment. This papyrus was found in 1862, and it dates back into ancient Egypt. But this is the first mention that is known of cancer. Cancer was a rare disease in the 1800s, 17 and 1800s, and it was only in the 20th century that we saw cancer start taking off. Here you can see in 1900, the death rate from cancer in the United States was, for every 100,000 Americans, there were 64 cancer deaths. Now, age adjusted, taking away the aging of the population, that rose to 215 deaths per 100,000. That's almost 3.5 times increase over 91 years, peaking in 1991. And from 1991 to 2015, 2016, the last years that we have data, there's been about a 26% decrease in cancer mortality, which is a good thing, and it's something that we'd like to continue. Now, age-adjusted cancer death rates have decreased by 26%. The American Cancer Society, which I used to work at, estimates this year there'll be about 1.8 million diagnosed and about 607,000 who are going to die. That 26% decrease is a wonderful thing. We just need to continue it. The most commonly diagnosed cancers are shown here: prostate, breast, lung, colorectal. These four account to more than half of all cancers. The most common causes of cancer death are shown here: lung, breast, prostate, and colorectal in that order. And again, they account for about half of all cancer deaths. In women, the most commonly diagnosed cancer and most common cause of cancer death is lung cancer, followed by breast, colorectal, and pancreatic. The 26% decline is estimated to mean that over 2.3 million Americans did not die a cancer death over that 25-year period. The fact that that number started going down translates into 2.3 million Americans not dying. That's actually a really, really good thing. Now, the reason why the decline: wise early detection and wise screening, especially in colorectal, breast, and cervical cancer. I say wise because there is such a thing as unwise screening, and there are people who are actually hurt because of our over-exuberance in screening and not doing it wisely. Cancer prevention, especially tobacco control, smoking cessation, and prevention of people from starting to smoke. And I'll note right now that the average age that a person starts smoking in the United States is 16. Very few people start smoking after the age of 18. So it's a pediatric problem. Dr. LaRocque, I had to say that. And improvements in cancer treatment. Now, cancer screening can be beneficial, it can be harmful, it is often both, and only a good randomized trial can tell you whether or not a cancer screening intervention is effective. And when we do cancer screening effectively, we do it in programs. So frequently people talk about one-off, just getting a mammogram. I want people in a program of mammography where they get it regularly. You know, they talk about every year, every 2 years, regularly, so that people can have previous exams for comparison and that sort of thing. We need to follow the good science. This is from Graham Colditz at Washington University in St. Louis. These are the causes of cancer and the potential for cancer prevention. I want you to note that 33%, a third of all cancers, are caused by tobacco. What is frequently not appreciated is 20% are caused by the condition of being overweight or obese. Diet and lack of exercise account for 5% each. Literally, 30% of cancers are caused by energy balance issues. Energy balance is obesity, too many calories, and not enough exercise. And then occupation viruses, alcohol causes cancer. And UV and ionizing radiation, a lot of those screening tests that we take, 2% of all cancers in the United States are now caused by medical radiation. So we need to be careful. Tobacco is still a leading cause, though, at 33%. And it's actually going down in almost every disease except bladder cancer. By the way, 55% of American men smoked cigarettes in 1955. It's now 16 to 17% overall today. 35% of American women smoked cigarettes in 1965. It's now about 12%. Trends are good. Some state variation, which you're going to see a little bit of in a bit. Cancer is caused by infection. This is something we really didn't even appreciate 60 years ago, 50, 60 years ago when many of us were born. The liver cancers are caused by hepatitis C and hepatitis B. Hepatitis B is vaccinable. Hepatitis C is actually treatable, and 90+% of people with hepatitis C can be cured with a medical treatment that costs about $30,000. Unfortunately, that treatment is not available for many people in the United States, and that's part of what we're going to talk about with disparities. Head and neck cancers, as well as cervical cancers and 4 other genital cancers, are caused by the human papilloma virus. The human papilloma virus, many of the viruses that cause cancer are now preventable through a vaccine. And uptake of that vaccine is greater in Rwanda than it is in the United States. Again, this is an issue for what we can do in the United States. Already talked about the problem of energy balance. Too many calories, not enough exercise, and obesity. It's not just obesity alone. 2/3 of adults and 1/3 of children are overweight or obese in the United States. You'll see another slide about that right now. This is obesity in some of Otis's favorite countries. You see in 1970, 15% of Americans were obese. Today it's 35%. Look at England, Canada, Hungary, Spain, France, Switzerland, Korea. Far, far lower than in the United States. One of the issues in cancer control is actually lifestyle issues and how we live. This zeroes in on blacks and whites, and you can see this is a special problem in non-Hispanic black women, where 60% of non-Hispanic black women are currently obese. It's a rise in all Americans, but it's especially a rise in non-Hispanic black women. Now let's look at some specific cancers. In 2019, the American Cancer Society estimates 269,000 diagnosed, about 42,000 or so who are going to die from the disease. There has been a 40% decline in death rate, age-adjusted death rate, in breast cancer in the United States from 1990 to 2016. 40% decline. That means your average woman who's in her 50s today, her risk of dying from breast cancer is 60% of what it was for a woman of the same age in 1988. That is true progress. Screening, by the way, is attributed to 40 to 50% of that improvement, and more people just saying, what is this, and going to the doctor, which is really early detection, not screening, and improvements in treatment are the other 50 to 60% of the decline. 40% overall. This is the death rates per 100,000 for the 4 OMB categories of race and ethnicity in the United States. Most people don't realize the White House defines race 2 years before every census, and it actually changes, so you have to look at the definitions. Blacks in red here, whites in blue, and then only started looking at Asians, Pacific Islanders, Hispanics, and Native Americans in 1990 onward. But we've got data for blacks and whites going back to 1900, actually. You can see there was no death rate difference for blacks and whites until about 1981. We learned how to screen and treat for the disease, and all of a sudden we have a disparity by race. There was no disparity by race before we learned how to screen and treat for the disease. The death rate's actually, the delta, that is the disparity between blacks and whites for death rate, is greater today than it's ever been, and it didn't exist prior to 1981. So that's looking at disparities by race. I want to note there's 7 states in the United States that do not have a black-white disparity in death rate. There's certain states that don't have a disparity in black-white death rates. They do something a little different. Now, I told you there's a 40% decline in death rate since 1988 to 1990 to 2016. This map of the United States shows you the states that have had a 44 to 51% decline in dark blue, and they're located in North Central America and northeastern United States, and the states that have had a 20 to 29% decline in cancer mortality, and those are the purple states here. Why is it that women in Massachusetts have had a 51% decrease in risk of cancer death over the last 30 years, whereas women in Mississippi have had a 20% decrease? You see, I started out talking about disparities by race. Now I'm talking about disparities by Massachusetts versus Mississippi. This is not a racial issue. This is a where people lives issue. By the way, lots of emphasis. When I was chief medical officer of the American Cancer Society, and Judy had it when she was at Komen as well, lots of interest in screen. This is good work by Jeannie Mandelblatt at Georgetown, looking at mathematical modeling. And important here, you need to know, a substantial portion of women with breast cancers, about 40%, have something wrong with their treatment. This is not 40% of black women, this is 40% of American women have something wrong with their treatment, something that I as a medical oncologist would be uncomfortable for. It might be dosing of chemotherapy or not getting chemotherapy. It might be aiming of the radiation beam, quality of the surgery. Sometimes it's getting prescribed 6 weeks of radiation and dropping out 2 weeks into the 6 weeks. That's actually incredibly common. But 40% that have something wrong with their treatment. In this study, literally, it's a lot of wording there. It basically says, if we treated everybody that we diagnose correctly today, we would actually save more lives than if we went from the 60% of women who are getting regular screening to 100% of women getting regular screening. I have yet to see a congressperson come complain about getting people high quality care, but I can guarantee you the next time we change the age at which people should start screening, there will be at least 24 congresspeople screaming at the chief medical officer of the American Cancer Society or the physician at Komen. We so frequently get lost in our rhetoric. I mean, the screening issue is not the problem. We need to treat people. That's a logistical issue. Now let's look at colon cancer. 101,000 diagnosed with colonic cancer, 44,000 with rectal cancer, 51,000 deaths from colorectal cancer this year. There has been a 50% decrease in colorectal cancer death rates since the early 1980s. An average adult today, their risk of dying from colorectal cancer is half what it was for the average adult in 1980, and screening is about 2/3 of that decline. Here for women with colorectal cancer by race again, age adjusted from 1970, no death rate differences for blacks versus whites. We learned how to screen and treat the disease, and then there's a delta. There is a difference in death rate. And these are the other three racial ethnic categories that OMB started collecting in 1990. But you can see the delta or the disparity for black and white women. Now I'm going to show you black and white men, the disparity again. Very little disparity. It was actually a white disparity in the 70s for black men. That's probably underdiagnosis in black men. And then the disparity for black men versus white men throughout the 1980s, 90s, and into 2015 or so, 2016 or so. And you can see there was no disparity until we learned how to screen and treat. That's the black-white disparity. This is a graph that I actually prepared when we got a little political. I prepared this when I was at the American Cancer Society as a support for the Affordable Care Act. And I hate survival data, by the way. It's so frequently misquoted and misunderstood. So I don't usually show survival data, but this time I will. This is 5-year survival, 60 months on the x-axis, 70%, 80%, 90%, 100%. Stage 1 colorectal cancer in red, stage 2 colorectal cancer in blue. Insured are the solid lines, uninsured are the dotted lines. And I prepared this just to show 5-year survival for stage 2 insured patients in the United States is better than 5-year survival for stage 1 uninsured. In the United States of America, you're better off having more advanced colorectal cancer with insurance than less advanced colorectal cancer without insurance. And at every stage, stage 1, stage 2, stage 3, stage 4, insured live longer than uninsured. This was just prepared to show that insurance matters as to whether you live in the United States or not. This is death rates by state, or the decline in death rates by state. I told you 50% decline since 1980 in the United States overall. It's 56 to 63% in those blue states in the Northeast. It's 12 to 31% in those purple states. Why has there been a 63% decreasing risk of death from colorectal cancer in Massachusetts and a 12% decrease in Louisiana? This is a problem. Unless we want to argue that people in Louisiana are genetically different from people in Massachusetts. And I would entertain that as possible. I've been to Louisiana. This is a study done by a wonderful young surgeon at Stanford named Kim Rhodes. Kim Rhodes looked at something very interesting. The American College of Surgeons and all the pathology organizations, they say that you should have 12 lymph nodes examined by the pathologist after a colorectal cancer surgery. And she actually looked in the California registry, and she found out that Hispanics and blacks and poor people very frequently have a lot less examined than whites. It was actually an average of about 6 for blacks and about 18 for whites. And not to get too complicated in a mixed audience, a lot of the blacks who were stage 2 because they had 0 out of 6 lymph nodes positive. 6 lymph nodes were looked at, none had cancer. A lot of those stage 2 patients will relapse, and a lot of the stage 3 white patients who were stage 3 because they had 18 lymph nodes looked at and only 1 had cancer, a lot of them never relapsed. And that's how we got into this belief that colon cancer is more aggressive in black people. Okay? It's really a form of systemic racism that caused us to have that, and it's the understaging of the blacks and overstaging of the whites. And so Kim actually said, I know some pathologists, they seem to be nice people, they're not racist. How did this happen? And then she realized that a large proportion of the blacks in California are treated at overcrowded hospitals where a pathologist generally has 6 cases to deal with per day, and a large number of the whites are treated at nice, plush hospitals where the pathologist has 1 or 2 cases to deal with per day. So you see, this is really systemic racism that actually led us to come up with this biologic belief that colon cancer was more aggressive in blacks versus whites. So there are huge differences in the quality of medical everything from screening, treatment, how pathology is handled in the lab. Huge differences. Usually they're socioeconomic, they're not racial. Sometimes they are socioeconomic because of race, sometimes they're socioeconomic because of where people live, the Old South versus the Northeast. There are differences or disparities by race, socioeconomic status, region of residency, and other things. Lung cancer. The estimates from the American Cancer Society, 154,000 deaths this year. This is looking at mortality rates by states. You'll note many of those states that were purple before are dark red now. These are the states that have the highest death rate from lung cancer. These are also the states that to this day, keep in mind there's a 30-year lead time. If you look at the smoking prevalences by state 30 years ago, these were the states that had the highest amount of smoking. They haven't changed very much. West Virginia and Missouri and Arkansas, they haven't changed very much. And by the way, Utah and California have the lowest prevalence of smoking today at 10%. West Virginia, Missouri have the highest prevalence at 28-29%. But there are certain places, Baltimore City where I live, 1/3 of all adults smoke. There's several cities in the United States and several rural counties where it's still 40% of people smoke. Tends to be a poor person's disease today. By the way, when I say 10% prevalence of smoking in California, I guess I need to specify, I'm talking about tobacco here. This is the death rate from lung cancer or from overall mortality in Kentucky versus Utah. It's heavily driven by lung cancer smoking. Remember, 10% prevalence in Utah, almost 30% in Kentucky. Lung screening. Lung screening is complicated. I know there are some people in New York who are really behind some of the early studies in it. But the big lung cancer screening study of 54,000 people that screened people who were heavy smokers because they were over 55, high risk, over 55 heavy smokers, but still in reasonable health, done in 30 of the finest hospitals in the United States, showed that after 10 years, there was a 20% reduction in risk of death in people who got screened versus people who got the sham screen that didn't work. Now, I'm a screening epidemiologist. 20% relative risk reduction doesn't do it for me. You see, I know there's harms and there's benefits. If you screen someone and you say there's something there and you say, gee, I need to biopsy, you stick enough needles in people's chests, some people are going to have a complication or two. For every 5.4 lives saved in this study, 2 people went to the ICU and 1 person died. The study saved lives net, 5.4 lives saved for every 1 life sacrificed. That's a screening test. The screening implementation caused you to do the bronchoscopy or caused you to do the biopsy that led to the patient having a problem, a complication. Therefore, you have to account for that as part of the screening. It would have never happened if there hadn't been a screen. Keep in mind, that's when it's done in 30 of the finest hospitals in the United States. How does this go down in Poughkeepsie? Now, approximately 160,000 are going to die from lung cancer this year. If we had screening for everyone at that incredible expense, we would prevent 8,000 to 10,000 deaths, and we would kill 1,500 to 1,850. If every hospital was like the 30 hospitals in this study, and every patient was like the 54,000 people who volunteered to go into this study. And every hospital in the United States is not Columbia Presbyterian or Weill Cornell or Johns Hopkins or the University of Pennsylvania or the University of Chicago, all who were in that 30 that participated in this. 6 respected groups recommend that the doctor consider screening for people at high risk, and that the people be informed, and those who understand the risks of unnecessary procedures and even death associated with screening, who want to get screened should get screened if they have high quality screening available. If they have high quality screening and treatment available. And that brings us to the most important question in cancer control. How can we provide adequate high quality care to include preventative services, the populations that so often don't receive it? Now, we can define those populations by where they live. We can define those populations by income, by insurance. We can define them by race. We should also know that unnecessary care interferes with institutional abilities to provide necessary care. I've seen so many people institute one-off breast cancer screening programs, and what they do is they flood the pathologists with specimens so that they don't pay good attention to the colon cancer surgery. There are state-by-state disparities, by the way, that are increasing with the Affordable Care Act. The orange states, you see a pattern? I went from purple to orange, but you see a pattern? And I notice I did not use red. These states in orange have not extended Medicaid in the Affordable Care Act. And what we're going to have over the next 10 to 12 years are increasing state-by-state disparities as people in the blue states have greater opportunity for health care, and people in the orange states have less opportunity. Last couple of slides. On my way out the door at the American Cancer Society, I decided to try to define or quantify the disparity in the United States in terms of cancer. How many people die because they don't get what they should be getting? And how we did that is we noted that college education is a wonderful thing. College-educated black men have a lower risk of cancer death than white men in the United States as a whole. You give a college education to any group of people and you lower their risk of death substantially. So, the American Cancer Society every year estimates how many people are going to die from cancer. It's 607,000 this year. We ask how many people would die from cancer if all Americans had the risk of death of college-educated Americans. This is not a new screening test. This is not a new drug. This is not a new surgery. This is not a new anything except the idea of getting every human being what we've already defined that human beings ought to get. The answer is 455,000 would die instead of 607,000. A quarter of all deaths, 152,000 deaths this year would go away if everybody had gotten everything that everybody should get. Now that includes a lower 5 or 6% smoking rate starting 30 years ago. But that's the number of lives lost because of our inefficient healthcare system. And the amazing thing about that 152,000 is 110,000 are white people. The disparate population in the United States. Now, when I started 30 years ago doing this, health disparities was black-white. Now we're starting to realize that the biggest disparate population in the United States are white Americans, primarily white Americans from the Old South. The issue of health disparities is not just a racial minority issue anymore. Now, population disparities have increased, and I showed you, as we get improvements in screening and treatment, I showed you the black-white disparity increasing. We're going to see that more and more in the United States, increasing disparities as we improve. We're going in this era of precision medicine and immunotherapy, and cancer treatment's actually getting much better than it was when I started 30 years ago. New preventive measures, by the way, don't cause disparities, but with these new treatments, we're going to see more and more disparities. When I say preventive measures don't cause disparities, there are no racial or economic disparities in this country in smallpox. There's not even disparities by race in measles, things that we can prevent. And so I'm really into prevention. I'm really into equity, and I'm really equity versus equality. The idea is that certain populations, we may define those populations as poor folks, poor white folks in Kentucky or poor black folks in the Bronx, need a little extra to get where we all want to be. Certain populations are going to need certain extra things. And I will leave you with that. Thank you very much.
Thank you, Dr. Brawley, for that very thought-provoking and nuanced look at cancer control. We have a lot to understand. So now we will begin our award ceremony. It's my pleasure to introduce Dr. Ann Buckingham Young, former Chief of Neurology Services at Massachusetts General Hospital, and the distinguished Julianne Dorn Professor of Neurology at Harvard Medical School. Dr. Buckingham Young will present the Academy Medal for Distinguished Contributions in Biomedical Science.
Thank you very much, Dr. Salerno. The Academy Medal for Distinguished Contributions in Biomedical Science is the oldest of the Academy Awards. The medal has been awarded since 1929 to a senior investigator with evidence of sustained accomplishments in biomedical research and a special interest in translating research findings to advance human health. It is an honor to present this year's award to Dr. Nancy Wexler. In recognition of her important and scientific work in discovering the location of the gene that causes Huntington's disease and her ongoing work to find treatments for the disease. Her lifetime dedication to the field has had powerful impact on the science and ethics of neurogenetic conditions. Now that was written for me, and you have a beautiful bio in your program that lists all of Nancy's incredible accomplishments and her achievements beyond any normal person. But I'm going to tell you about the time that I first met Nancy. I had come from my neurology residency at the University of California, San Francisco, to the University of Michigan. And Nancy, 4 years earlier, I was there in 1978, 4 years earlier, Nancy had gotten her PhD in clinical psychology there, and she did that PhD on being at risk for Huntington's. She also started the local Detroit chapter of the Committee to Combat Huntington's Disease. And when I came to Michigan, I was taking over the Huntington's Clinic. And that was because the senior clinician had left for another institution. So the local chapter was horrified. And they called Nancy up and said, what's this new doctor? And can you please come and check her out? So she arranged to give grand rounds, and she gave it on this project in Venezuela. And then I went out to lunch with her, and it was like I had met a force of nature. This woman, she was only 1 or 2 years older than me, but wherever she went, whether it was the jungles of Venezuela, to the little houses on stilts, to the barrios in the midst of absolutely nowhere, or from Papua New Guinea, Peru, all over the world, Nancy was completely at home. But amazing, she was completely at home in ballrooms with Nobel Prize winners and everybody else, and everybody who met her wanted to work for her and work on Huntington's and make it happen faster. She could persuade a brick to work on Huntington's disease. So to me, she's my best friend, and I love her, and she has done more for helping the Human Genome Project, solving this disease, and most importantly, because of her, there are now therapies in people for treating this disease by genetic methods, and there are also some companies that have oral agents that can treat this illness. So she's gone from knowing nothing about Huntington's disease to fixing it. So you rock, Nancy Wexler, and
you know my secret of success. I met Anne Young at a very early age. When I first went to Michigan, I was really writing my PhD on being at risk for Huntington's. My mother had just been diagnosed with Huntington's in 1968. She died of Huntington's 10 years later. And for me, having the possibility of all of your body and thoughts and brain and talent disappear because some marauder had taken over your life and your genes was unacceptable. But I found in Anne the same intrepid spirit. And it rocks actually by figuring out the whole mechanism of your brain and who talks the cells to whom. All the things we have right now for Parkinson's are because Anne worked out the pathways. When the two of us said, okay, let's go to Venezuela, we had to figure out how do you actually do the neuro exams? Touch here, touch whatever, walk here, walk there. All of us had to figure it out. And Anne and I went actually down on every single trip.
22
this trip,
years.
in this trip when we actually literally almost died because caught in a gigantic, literally a big gigantic storm. Literally, our boat was about to capsize because, we were drowning.
Yeah.
And Anne and I looked at each other because neither one of us had taken Dramamine. Neither one of us had even a life jacket. The people on the boat, the Venezuelans couldn't swim. Both of us were sort of saying, well, how do we figure this one out? And I had kind of had a little bit of training with our dad in a little tiny boat in Lake Tahoe. And so the pilot said, you know, he was going to go get something underneath. We had a lot of samples. We had collected critical samples from Lagunera, and they were actually bumping around, you know, and getting trashed. So the pilot said to me, Nancy, I'll steer the boat if you take it over. So I kind of channeled my dad's, you know, brain. Well, just like that, you're not going to drown in a following storm or be actually, you know, impacted. And so we, you know, we managed to, just by kind of slicing and throwing up and really just getting right to a rig. We had a gigantic gas rig that,
Propane
you know,
gas,
propane
yes.
gas that had just blown up month before. So we said, okay, let's just go to that gas rig. And that's, you know, how we managed to get there. And Ann and I and all the kind of big husky men, neurologists and Venezuelans, were throwing up. So we really had to kind of, you know, leap on and make sure every single one got into the propane rig. And the men just looked at the propane rig because they had all blown up before. They said, how, why, what rescue you got? Well, first of all, what were you doing out in the middle of the night? We were really working with one of the local oil companies who gave us a boat. They never should have even looked, you know, for any staff person going back and forth. That was our problem to start out with. But then they said to us, well, clearly God saved you. San Benito was a kind of God. God saved you, and you got saved because you're going to cure Huntington's.
Yep.
And you're going to bring it to Venezuela. So we were linked by, really, you know, linked really by the soul. And the fact is that now there is a Roche drug. Now there really is an oral. We are also looking, you know, we're sequencing that entire, the genome, and we're actually finding a gene called Alpha that extends life by 23 years in the Venezuelans. We're sequencing FAN1. And all of that really is just from really, really, and all the Venezuelans. So thank you, thank you.
Yes.
Definitely.
Congratulations again, Dr. Wexler. Now I'd like to introduce Dr. Bobby Berkowitz, Dean Emerita and Professor at the Columbia University School of Nursing and a member of the NYAM Board of Trustees. Dr. Berkowitz will present the Academy Medal for Distinguished Contributions in Health Policy. Bobby.
So that is a hard act to follow. I think I'll just throw this away. Oh, well, it is an honor to be here and to reintroduce you to someone that I think you all know very well, and that's Dr. Diana Mason. You have Diana's brief bio, so I'm not going to give you the whole back history of her. The brief bio does not do justice to the career of this woman. It is indeed impressive, and the few paragraphs that you have already read or will read cannot capture the extent of her impact on the field of health policy. So this award that she is about to receive is for distinguished contributions in health policy, and it was established in 2008 to recognize an individual who has created evidence through their own research or applied evidence and experience through their public service, community service, or advocacy to promote significant policy change in the health system to improve the health of the public and to eliminate health disparities. Diana's work exemplifies the criterion, and she is the perfect fit for this award. So I've known Diana for some time now, in many aspects, but primarily through our work within the American Academy of Nursing. We worked together on the Academy board. We worked together as president and president-elect. We strongly believed, and this was really Diana's leadership, that the Academy could impact health policy through the concerted efforts of Academy Fellows and through the publication of policy briefs, often directed at Congress. That's what we felt, but getting that action going was really Diana's contribution to the work of the Academy, but also what we have all experienced. It was her vision and goal that the action would in turn strengthen the health of our people, similar in many ways to the work here at the New York Academy of Medicine. Diana's leadership within the New York Academy of Medicine, the American Academy of Nursing, her policy-related blog, her significant publications on health policy have been pivotal in assuring advances in the health of the public. Diana embodies the values and focus of this award for her seminal work in health policy, and therefore, it is my great pleasure to give her this, here we are, to present her with this award.
Thank you.
Where is it? Right there, okay.
Thank you so much. I am deeply honored to receive this award, particularly in the company of my esteemed colleague, George Thibault, the likes of Mary Bassett, and the other honorees, and certainly Nancy Wexler. I want you on any boat I'm going on. Claire Lemieux was a Canadian-born nurse who was recruited in the 1960s to West Virginia University to design and implement an innovative curriculum for a new school of nursing. And that was my alma mater. Now, many of you know WVU is a party school, and I did get my share of partying in. But the School of Nursing didn't leave you with much time for that. It was the most innovative curriculum I have ever seen then and now. We had public health threaded throughout the curriculum. We followed through the public health department a developing family the whole time we were in school. We took care of people in their homes and in the community, and then we followed them into the hospital when they had surgery or they delivered a baby, and then we followed them back to the community and took care of them at home. This was transitions of care. They were doing that work before it was in vogue to even talk about it. They were doing it. And we had 2 community health nursing courses. And Claire Lemieux was my teacher in the first one. And she walked into that classroom with an armful of newspapers, gave us each a page, and said, here, find something on your page and relate it to health. Well, I had the business section, and my friend had the style section. And we looked at each other and said, well, nothing here. And Claire proceeded to show us that there was something on every page of that paper she could relate it to health. She showed us that health is shaped by the conditions of our lives, the conditions of our communities and our families, and that if we wanted to influence those conditions, then we had to pay attention to the policies that were being put forth, both public and private sector. She taught us that policy matters, and Dr. Brawley just showed us that policy matters as well. So it matters whether people have health insurance. It matters if the government has policies that are removing children, separating children forcibly from their parents and warehousing them in detention facilities, despite the evidence that these children will be traumatized emotionally and physically, not just in the short term, but throughout their lives, with higher rates of chronic disease and other health problems and higher mortality rates. Policy matters. And it matters. It matters. And it matters when government reverses policies that were put in place to protect the health of the public by protecting our environment. Those policies matter. And it's not just what governments do, it's what our own healthcare organizations do. So when hospitals and healthcare organizations have policies that reflect more of a priority for high-tech care than the high-touch care that's provided by nurses and physicians and social workers, et cetera, patients are affected. We have reams of data showing that nurse staffing, inadequate nurse staffing, is related to higher rates of complication and death. So Claire taught me that policy matters. And I want to thank the New York Academy of Medicine for really understanding this, and particularly around the social determinants of health. Thank you for the work that you're doing. And I want to thank the nursing section of the New York Academy of Medicine. Yay! They nominated me for this award, and is Connie Vance here? Yes, Connie Vance, the founder of this section. Thank you so much for your leadership. Thank you. And with people like Barbara Glickstein, Donna Nikitas, and now a new generation of leaders in Toby Bresler, Maria Vizina, and Allison Squires, it's a vibrant nursing section that's totally committed to the interprofessional work of this academy. In closing, I want to dedicate this to Claire Lemieux. About 10 years ago, I realized what an impact she had on me, personally and professionally, and I wanted to tell her. I couldn't find her. None of my classmates knew where she was. Former faculty didn't know where she was, so I Googled her, and I found her. And I found that she was living just a few hours north of where I'm now pretty much living in upstate New York. And I was excited, and then I scrolled down and found that she had died 2 years earlier. So I dedicate this award to Claire Lemieux in deep gratitude for participating in my awakening. Thank you.
This is an exciting night, isn't it? Congratulations again to Dr. Mason. Please welcome to the podium Edward Henry, President and Chief Executive Officer of the Doris Duke Charitable Foundation. Mr. Henry will present the Stephen Smith Award for Distinguished Contributions in Public Health.
Thank you, Judith. I just realized I am totally out of my league because I'm not a healthcare professional. Whoa. But it was just about 11 or 12 years ago when I stood in my kitchen. I think it was a Sunday afternoon speaking to Mary Bassett for the very first time on the telephone. and I'm sure it was a landline. I wanted to convince her to join the foundation, the Doris Duke Charitable Foundation, and lead our African Health Initiative and our Child Wellbeing Program. Thankfully, she accepted. Just recently, we were talking about her work as professor and director of the Center for Health and Human Rights at the Harvard School of Public Health, a new platform to continue her commitment to advancing health equity globally. And as you may know from reading her bio, and I'm skipping all of the details, between leading our programs and her current program, she was commissioner of the New York City's Department of Health and Mental Hygiene. That is one big job, an enormous opportunity to have an impact on millions of people. And that is one big culture to change. Now, Mary's bio does note that Mary lived in Zimbabwe for almost 20 years, served on the medical faculty of the University of Zimbabwe, and has been involved in practices of clinical work and public health throughout the continent of Africa. However, a group of us were in Mozambique for a program that Mary was leading in strengthening health systems, and we were all gathering for lunch. Mary came and sat with us, and she noted that on the exterior of her building, she saw an amazing thing. It was a lizard, which was exactly the color of the wall. Well, Mary had lived in countries with lions and tigers and elephants and insects. In a way, we were all aghast, in a humorous way, of course, that she didn't realize that that was the job of the lizard. I mean, it was in their DNA to change colors and blend with the background, to hide from predators. Well, that's probably because Mary never felt the need to hide. From day one at the health department, she embarked on an effort to apply a social justice and racial equity lens to all of the department's work. From educating staff about the role of race in the United States, both historically and today, to changing the leadership to better reflect the constituency of the health department, to encouraging and supporting the expertise of her staff and expanding their community engagement. The Medal for Distinguished Contributions in Public Health, first awarded in 2005, was named for Stephen Smith, an Academy Fellow and a pioneer in the field of public health. The criteria for this award are that the recipient will have led or significantly contributed to work that affected a significant change in public health policy or practice to improve population health, including work on the broader determinants of health. It is an honor to present this year's award to Dr. Mary Bassett for her work as a New York City Health Commissioner. In this role, she profoundly influenced public health in New York City, especially by addressing structural biases in order to advance population health. With racial justice as a priority, she established new structures to help close the persistent gaps in health based on race and economic factors. Her work included multiple initiatives on social determinants of health, the opioid crisis, mental health, and health equity. Just one further note, true fact. When Mary was a student in Boston, she worked at a free health clinic in Roxbury, one of 13 established by the Black Panthers, who, in their evolution, had identified public health as a social justice issue. Mary cajoled doctors to be volunteers, and then she ran a sickle cell screening program using medical students who she had wear their white coats and go door to door in the community, and then arranging follow-up care with the hospitals. This was important work, early work in community health and public service, but some would consider all of this controversial because of the association with the Black Panthers. And it was because of that misunderstanding and the endless distraction it might cause that Mary decided to not run for president in 2020. Since we cannot persuade you to change your mind on that, we congratulate you as a 2019 recipient of the Stephen Smith Medal for Distinguished Contributions in Public Health.
what an incredible evening. I was assured that I just had to say thank you, thank you. So let me say thank you to the Academy and to its president, Judith Salerno, for continuing to elevate the issue of advancing health equity. We've heard it from our speaker this evening, and it continues to guide my working life. Before I became health commissioner, I worked for Ed Henry for 6 years, and I would like to acknowledge him this evening because I learned from him what it means to be a leader who trusts their team, who aims to support them in their work, and who lets them take credit for their work. So when I became health commissioner, I decided that was the kind of leader I would be. And the health department rewarded me and this city by doing its level best to embrace the ideas of racial justice and health equity. Really, this award belongs to the New York City Health Department. And I have confidence that they will continue that work. So I thank you all for honoring me this evening. With credit to the men who will follow, what a group of women you have selected. And I thank you, Ed, for teaching me what it meant to be a leader.
You see, Mary, we missed you so much here in New York, we found a way to get you back. So, congratulations. It's now my pleasure to introduce Dr. Arthur Rubenstein, Professor of Medicine in the Division of Endocrinology, Diabetes, and Metabolism at the Raymond and Ruth Perlman School of Medicine, University of Pennsylvania. Dr. Rubenstein will present the John Stearns Medal for Distinguished Contributions in Clinical Practice.
Dr. Salerno, ladies and gentlemen, the Medal for Lifetime Achievement in Clinical Practice was established in 1992 and named for John Stearns, the first president of the Academy. The medal honors extraordinary contributions to the clinical practice of medicine, including in disease prevention, treatment, or rehabilitation, also physician-patient communication, clinical medical education, or medical ethics. I am indeed honored to present this year's award to Dr. Philip Pisa, my really good friend, for his dedication to the diagnosis, management, prevention, and treatment of childhood cancers and the infectious complications of that disease which occur in children, and particularly those whose immune systems are compromised by cancer and AIDS. Of course, it is a significant challenge to add meaningfully and to add in any kind of detail the significant comments and summary of Dr. Pisa's career, which is printed in the program. And those of you who would look at it will see that he has published more than 600 publications, received honorary degree, election to membership, and leadership of numerous important national and international societies and organizations, and inspired successful leadership of many, many mentors and students over many, many years. He's of course been a great leader at the NCI, the Children's Hospital in Boston, and finally at Stanford Medical School. However, a clue as to what to emphasize is expressed in John Stearns' citation. That is, it honors an individual who has made extraordinary contributions to the clinical practice of medicine, including disease prevention or treatment, and rehabilitation and medical ethics. In this regard, I'd like to emphasize briefly a few highlights from Phil's illustrious career. In 1973, Phil was given the responsibility of taking an 11-year-old boy in Bethesda who had aplastic anemia and a compromised immune system who was being cared for at the NIH Clinical Center. You might remember that Teddy was one of the youngsters labeled the boy in a bubble. There was one other colleague elsewhere in the country. And that was because he was confined for 24 hours a day to a small room with a physical barrier into which sterile air was blown. Phil took care of Teddy over 7 years and became his link to the outside world, seeing and looking after him nearly every day of his life. It sounds like a thing a physician would do, but for a young physician, pediatrician like Phil, this was a responsibility that was quite enormous. And the description of how he looked after this boy and his family over many years until he died is really quite extraordinary. The second pivotal event I would mention was Phil's recognition that everyday emphasis of HIV/AIDS in particular, when it occurred to children, was something that was becoming very important in the early 80s. In particular, as a pediatrician specializing in infectious disease, Phil soon appreciated the importance of doing clinical trials with new therapies of infected children with the emerging disease, which many people at that time, of course, were extremely frightened about and didn't want to even look after these patients. This pioneering work, despite significant opposition and many challenges, which I don't have time to describe, but when you read about him, is really remarkable, stands as a beacon of what a courageous physician-scientist can accomplish with dedication and perseverance and the commitment to do the right thing with the highest ethical standards. It has inspired me, even these many decades later, just to read about him and understand how difficult but important it was. In the short time available, I mentioned briefly just a few additional contributions that Phil has made. The first is his leadership on behalf of the National Academy of Medicine of chairing committees that produced two remarkably influential reports. The one, Relieving Pain in America in 2011, and another one which I advise you all, if you have time to read, it's so really beautiful in many ways, Dying in America. These reports deal with difficult topics, but are a model of clarity, thoughtfulness, and impact. I would stress that following the publication of these reports, Phil wrote several really brilliant articles in major journals which highlighted the report but put it in more human and even personal ways. Those of you who read these articles will be impressed by Phil's remarkable humanity and the ability to express himself lucidly and beautifully by way of his narrative medical writing. The final comment I would like to make is Phil's recent creation of the Distinguished Career Institute at Stanford University, and now with offshoots developing all over the US and the world. This innovative program is directed towards middle-aged and successful individuals who wish to redirect their lives to embrace new opportunities and challenges and to try to give back in the best of ways to the community and the world, a topic that Phil has done at the highest level. In conclusion, I'd like to mention that my personal friendship with Phil over the last many years since he and I were deans together has been one of the most transforming relationships in my professional life. And I want to say, Phil, just how indebted I am to you for being such a remarkable role model, mentor, and just an admirable person. Thank you so much. So it is a great pleasure for me to present the John Stearns Medal for Distinguished Contribution to Clinical Practice to Dr. Philip Pisa. Phil?
Well, thank you so very much, Arthur, for those extraordinarily wonderful comments. I want to also begin by thanking President Salerno and Chair Flynn, and of course the selection committee. I have to say that when I got word of this award, my first reaction was total surprise. And then when I looked at the list of prior recipients, which parenthetically included Dr. Rubenstein in 2007, I was deeply humbled. In fact, so humbled that it revealed something that I suspect some of you have had in the past, which is really the imposter syndrome. Now, I also have to say that I am particularly honored because I grew up here in New York City. I went to college and medical school in New York. I was the beneficiary of scholarships along the way because I was really the first person in my family to graduate from high school. So I've really thought a lot about the power of meritocracy which exists in this country. And I was particularly reflective on this evening when the new nominees and the students were coming forward, and I looked at and witnessed the incredible diversity of the individuals who were standing before us, and reflected on how important that is to celebrate today at a time when our nation sometimes seems to be losing its moral compass, particularly our national leaders. So I also, in thinking about this, want to thank all of my colleagues and trainees over the years, countless ones of them, who came together really in concert with children and families to take on some of these extraordinarily important health challenges. It was really they, as a combination of bringing basic science into clinical medicine, who helped to change the face of disease. When I started my work in the early 1970s, childhood cancer was fatal in almost everyone. Today, as you know, almost 90% of children are long-term survivors or cured. When infectious complications were the #1 cause of death in those undergoing cancer therapy, today we've developed ways of really treating and even preventing them. And of course, the saga of HIV disease in children, once so horrible, is now treatable and even preventable. These are tributes to countless individuals working together to really bring knowledge to the relief of children and families. And in my mind, it's their faces that stands before me as I'm here with you this evening. And it's on their behalf that I want to say thank you very much for this award.
Congratulations, Dr. Pisa, one of my personal mentors. Now I'd like to introduce William Wright, Chair of the Board of the Josiah Macy Jr. Foundation. Mr. Wright will present the Academy plaque for exceptional service to the Academy.
Good evening, everyone. Exceptional service to the New York Academy of Medicine has been recognized since 1952 with an award of distinction for fellows and affiliates of the Academy. Individuals are recognized for sustained engagement with the Academy over an extended period, making major contributions to the success of the Academy's mission and programs, its role in the broader community, or its organizational growth and development. It is my great pleasure to present the final award of the evening to Dr. George Thibault for his visionary leadership as a member and chair of the Academy's Board of Trustees. His strategic thinking and altruistic contributions position NYAM to thrive in the future. In January 2008, at his first Macy Foundation board meeting, George Thibault assessed the environment of the nation's healthcare system and current education for healthcare professionals, and then provided a vision for change in the education system. The board, composed of leaders in the health professions and in education and business people, were riveted by what he said and set out for us. It was a roadmap for the next decade that in retrospect needed little revision. That being said, it called on the Macy to take an even more engaged role in redefining how we approach education and how we were to be the agent of change, most notably in the realm of interprofessional education, curriculum development, and faculty leadership development. Every foundation board wants to know the impact, merit, and validity of its grant making. In 2017, the Macy engaged leaders in the field of measurement. It was a gratifying moment to receive their report, which placed us in the top 5% of foundations for the impact of our grants over the last decade. Beyond the quantitative assessment, the commentary shared with us said so much about the clarity of vision of the Macy under George Thibault's leadership. Further, in the search for his successor, we became aware of the previously unknown collateral benefit of his seminal achievement, the Macy Faculty Scholars Program. Institutions that either nominated a candidate or had one advance to the finalist stage were able to use that to elevate and advance the conversation about education at their institutions. In some instances, that alone led to programmatic change. George Thibault was an extraordinary leader of the Macy, forging new thinking and new paradigms for the education of health professionals, while burnishing the foundation's nearly 90-year legacy as a vanguard for change. Under his visionary leadership, Macy's star burned brighter than any of us could have imagined. He left behind a rich and impactful personal legacy that will continue to inform the Macy mission and the ever-evolving field of health professions education. Getting George to leave Boston for New York was the stuff of legend. But he did come and became a consummate citizen of this great city. Indeed, I wrote a letter to a co-op board when he decided to buy an apartment with his wife here in the city on the Upper East Side as a pied-à-terre. That being said, beware. He remains a Red Sox, Celtics, Patriots, and Bruins fan. As we all know, that can be a dangerous undertaking in this city. Please join me in congratulating the 2019 recipient of the Academy Plaque for exceptional service to the Academy, Dr. George Thibault.
So I decided not to wear my Red Sox cap tonight. So thank you. First, I want to say what an honor it is to be in the company of this extraordinary group of people who were honored tonight. And it's a privilege to be on the same stage in the same program with such illustrious people from whom I've learned so much. I want to thank Joe Ivy Buford, and I want to thank Judy Salerno for their visionary leadership of this extraordinary, unique, and historic organization, and for the partnership that I was privileged to have with them. I want to thank my fellow board members, Jim, my successor, and particularly Tom Morris, I know couldn't be here tonight, my predecessor, for the honor that they gave me to get to help lead this organization. It shows just how ecumenical the New York Academy of Medicine is, that a physician who spent his whole career in Boston was given this honor and privilege to lead this unique and quintessential New York organization. There is no Boston Academy of Medicine, there is no Massachusetts Academy of Medicine. So I feel so lucky that I got to be honored, to be privileged to work with so many wonderful people to help carry out this mission that's 172 years old and hopefully will go on for another 172 years. And in that spirit, I want to give a little call to arms to all of us in this auditorium who have benefited in some way from the existence of this organization, to remind us all that not-for-profit organizations are under siege around the country. Sources of funding are harder to come by. Confusion and competition about mission distracts us sometimes from both our supporters and our mission. For those of us committed and dedicated, that organizations such as this, that speak to values, that speak to enduring principles, are more important than ever at this time. We cannot take their continued existence for granted. They will continue to exist only if and when all of us who care about them give of ourselves, give of our time, give of our energy, and give of our resources to assure the continuity of these value-based organizations that we desperately need in our society more than ever. So I say thank you for this honor, thank you for this privilege of being part of this organization, and may all of us renew our efforts to see that organizations like this persist for the benefit of society. Thank you very much.
Once again, congratulations to Dr. Thibault and all of our distinguished honorees. I'm so delighted to count many of them among my friends and mentors throughout many years, so it was really a privilege to see them all honored here this evening. Now we will recognize another highly esteemed group of health professionals, NYAM's 30-year fellows. This year, 18 fellows met this impressive benchmark, and I'm delighted that 5 of them are able to join us tonight. They represent a combination of professionals committed to clinical practice, education, research, and policy in their fields, and we are proud to have them as longstanding members of our community. I invite you to read about their impressive careers and accomplishments in the program for tonight's event. I'd like to ask each of the 30-year fellows here to stand as I read your name and to take a minute to share with us what fellowship has meant to you and your career and what advice you have for the new fellows who were inducted tonight. Please stand when I read your name. Dr. Lawrence S. Brown.
I must confess that when I received the communication about my tenure, I was quite surprised. And I was surprised because of the fact that it has been that long since I have benefited from the relationship. And on that note, and for the sake of time, I recommend it to all, particularly our new fellows. Thank you.
Thank you. Dr. Ivan Grunberger,
Thank you. I appreciate this recognition. I became acquainted with this beautiful hall 37 years ago as a first-year urology resident presenting at the Ferdinand Valentine essay contest. It was a very nerve-wracking experience, but I fell in love with this building, with the library, and then continued my association through the New York section of urology, becoming eventually chairman of the urology committee of the New York Academy, and just the support for the research and knowledge sharing is wonderful, but the most wonderful thing about the Academy is its focus on urban health and public health and community outreach, and it's just a wonderful thing. And I just want to invite I'm always trying to recruit the young people in neurology to participate. I want to congratulate the new inductees, and I hope you continue this amazing work. And I hope to be around still for a long time to participate as well. Thank you.
Thank you. Dr. Jack L. Katz.
A 30-year fellowship is a testimony to survival and persistence, I think. But certainly being a member in a body that has the kind of breadth and depth of expertise the Academy has with regard to clinical practice, education, research, and healthcare is really a privilege. And I am thankful to Herb Weiner, who nominated me for membership here more than 30 years ago. And I urge the new fellows to take full advantage of the many resources that are available in the Academy.
Thank you. Dr. Eric R. Marcus.
I also was perplexed and almost discarded the letter. It couldn't be 30 years since I was sitting here being inducted. But I want to say what the Academy is to me because it's been one of my professional homes, a home for my intellect. The library here is arguably one of the best in the United States, even as libraries are being closed at medical schools. And it's also a home for my heart, my doctor heart, in the standards and values that this place upholds. And we have to realize that the growing industrialization of medicine is redefining quality as cost. That's not the professional definition of quality. The professional definition is doing it right, as best we know, according to the individual and their needs. Dr. Brawley very cogently pointed out the socioeconomic drivers of healthcare. Implicit in what he says, for me, quality costs. When I was in the Army, in the Medical Corps, my commanding officer, Dr. Richard Grady, a late member of this academy, said, "Eric, what's right for the man is right for the Army." This place is going to be a place, I hope, that says what's right for the Army will be right for Medicare for all.
Thank you. And last but not least, Dr. Judith Wiley-Rossett.
I realize that I am between you and having a reception in the wonderful library. And I came to the Academy before I joined as a student and learned incredible things from the books in the library and the resources there. And I've learned more and more about all the missions of the Academy, and the social justice one was so vividly displayed tonight. Thank you.
Thank you. Please join me in acknowledging and congratulating all of our 30-year fellows and our 2019 awardees with a final round of applause. I invite you all to join us for a reception in the library reading room on the 3rd floor. Thank you and have a good evening.